Hi, and welcome to episode 14, season 5 of the Fat Doctor podcast. It is Wednesday, the 9th of April, I think, I hope. Yeah, I'm going to say Wednesday the 9th. I'm your host, Dr. Ash Alami, a weight inclusive GP, who is very excited today to talk about what I have dubbed the lose weight or die narrative. Um, does that make sense to some of you? Some of you are going to understand this without me having to explain it. You go to the doctor and they give you the impression that if you don't lose weight, you're going to die. Like, die. It's quite a nebulous thing. What will I die of? A heart attack, a stroke, cancer. I'm trying to think what else you're going to die of. Those are the three, right? The big three. Um, And as I've said before, and I'll continue to say, you know what, folks, chances are you are going to die of a heart attack, a stroke, or cancer, possibly dementia. These are the most common causes of death in well, I'm not going to say throughout the world, but in the global north, for want of a better word, or Western society, whatever you want to call it. I still haven't found a decent enough word that I can use here that I don't find offensive. But you know what I'm saying. And parts of the world where I live, yeah, those are the main causes of death for people. And so yeah, you will. But the idea is that if you don't lose weight, you will. And more importantly, that it's coming soon. It's difficult to say when soon because the doctor doesn't sort of specify. They don't say you're going to die of a heart attack on the 20th of November 2045. It's very kind of nebulous, but there's a real sense of urgency. Do something now. We'll pay for it later. So I want to look at the lose weight or die narrative today. Um, I just like saying it. And in particular, I'm going to look at heart health. Just because it's one of the most common ones. It's one we talk about a lot. It's one we think about when we think about physical health. We're often thinking about the heart, right? We're often thinking about risk factors for heart disease. The main ones being high blood pressure, high cholesterol, and diabetes. Those are the main risk factors for heart disease, right? I mean, you could also include nowadays non-alcoholic fatty liver disease or MAFLD, as we like to call it. Metabolic syndrome is coming up. We like to sort of use all sorts of fancy words, but really it's the big three: blood pressure, cholesterol, HbA1c. That's what we really care about. And so I'm going to focus in on that instead of kind of avoiding it and going, folks, there's more to health than your blood pressure. I'm gonna take an alternative route today and talk a little bit about blood pressure and cholesterol, etc., etc. Um, and I want to examine how heart health has become a bit of a moral issue rather than a medical one. Once upon a time it was a medical issue. It's very reasonable for doctors, medical professionals to be concerned about your risk of heart disease. As I said, it's the number one killer in the UK certainly, and so preventing heart disease, very sensible thing to do, and that's a very good medical kind of not objective, like it's a good pursuit. It's a good pursuit for all healthcare professionals. The problem is that we start moralizing it, and that I think is very problematic. And medical advice nowadays is often wrapped up in this moral judgment rather than evidence, which would be much more useful. Um, and I don't know if you've heard of this term medical moralism. It's one I was sort of introduced to relatively recently, but it's basically something I've been talking about for a long time. I just didn't know that this was the term that people use. It's just this idea, this framework that basically frames health as a moral obligation and illness as a moral failure, as opposed to it just being like this is health and this is illness. We've now sort of saying, well, health is an obligation. It's a debt that you owe. It's a responsibility. And if you do happen to fall ill, well, that's a moral failing. You've done something wrong. And there's, in the same way that when it comes to nutrition and food, there's a lot of moralizing going on, like good food, bad food, junk food, etc., processed food, whatever. Like those have become quite moral judgments when it comes to food. We do the same thing. I don't know if you've noticed. We do the same thing in medicine. You ever heard of good cholesterol versus bad cholesterol? So, I mean, I get it. I know why we do it. We're trying to explain things in a way that people understand. When we talk about low density lipoproteins and high density lipoproteins, not everybody understands what that means. But, we've started using good and bad, haven't we? In fact, we use good and bad to talk about patients. Do you know that? Oh, yeah, well, you probably guessed that, but we do. We talk about our good patients. Oh, that's a good patient. Oh, not such a good patient. That's a bad patient. Or we use terms like compliant and non-compliant. This is a disgusting term. In other words, if you listen to me, you are compliant and therefore good. But if you don't listen to me, you are non-compliant and therefore bad. It sort of places the medical professional, the healthcare professional, in the role of judge and jury, doesn't it? Like, I have decided that this is the thing that you should do, and if you don't do it, well, you're non-compliant and you're a bad person, you're a bad patient, and whatever happens to you, that's your fault. That's the kind of moralism that we experience, especially when it comes to heart disease, because a lot of, you know, if you've had a heart attack or a stroke or any cardiac event, we now call this secondary prevention. It's happened. And now our job is to prevent it from happening again. So that's called secondary prevention. In other words, it happened and we want to prevent a second one. Primary prevention is it hasn't happened yet. You haven't had a heart attack yet. You might never have a heart attack, but we want to prevent it from happening. And primary prevention makes up a large bulk of the work that we do. Certainly in like primary care but actually even if you're a cardiologist, a lot of the work that you're doing is primary prevention. And that that has become again a kind of a very moral place to work in, where we are saying to our patients, you know, if you don't do something now, or if you do something now, if you're good now, if you're bad now, if you behave, you don't behave, if you're compliant, you're not compliant, then that puts you at risk. It's risk, isn't it? It's a risk. And it's not a risk that we can really quantify, even though we try very hard to quantify it, even though we have calculators, literally got a calculator to calculate your risk. It's still very flawed and not particularly accurate. It's very basic. And there is this kind of a real, it creates, in my opinion, a real barrier to effective care. When we start moralizing, that's it. We've lost people, and we're causing harm, as I'm sure you know. And we use these metabolic markers, for want of a better word, blood pressure, cholesterol, HbA1c being the three most important ones, as a kind of moral measuring stick, right? Like these numbers begin to define you. People can quote them at me. You know, like you can quote your, I don't know, your phone number or your social security number. Like you can quote, yeah, my blood pressure is da, 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 da. I know what it is. You know, once upon a time that wasn't the case. It was measured in a clinic and a doctor said something to you and you might pay attention and you might remember it, but you're not measuring at home every 5 minutes and you're not being told how important it is. And so it's kind of one of those things that you learn about yourself, rather like, you know, I don't know, your blood type. And then you don't really think about it unless you're bleeding or you're giving blood. And that's what blood pressure used to be like. But now it's like part of our core identity. And it's used because it's now a part of our like our it's a moral issue. Now it's become part of our identity. We've begun to oversimplify things in order to to maintain those moral judgments as well. Like I said, bad cholesterol and good cholesterol. We've really oversimplified something very, very complex in order to, I mean, we to start out with to educate patients, but it's become a thing like, you know, you want to be good. You hate when you're having your blood sugar measured, you want it to be good, good sugar, good sugar level, good HbA1c. And if it goes up, oh, bad, I'm a bad person. I've done something bad. Yeah. Whereas actually, blood sugar, again, especially over time, really isn't related to what you do or what you eat, or you know, it's much more complex than that. It's not going to really change. Your HbA1c isn't going to massively change because you had a slice of cake one day. It really isn't. I know that that's the impression that we gave. You touch sugar, oh, oh gosh, that's it. Sugar's going up, and it may well increase at the in the moment of eating it, of course, but that's not going to have a long-term effect because for the vast majority of us, unless you're a type 1 diabetic, for the vast majority of us, our body is able to handle that sugar. Some are better than others, but that's not your fault. That's just the situation. Um, but this idea that, oh, you know, that's terrible. Your blood sugar, terrible, terrible, very low, very high, very this, very that. And so it really becomes a marker of success, and beyond that, just a marker of like whether or not we're decent human beings. And we become really ashamed, right? If you get told your cholesterol is high or your blood pressure is high or your A1C is high, that creates shame, immediate, instantaneous shame. Oh, I'm a bad person. I'm a non-compliant person. I don't care. I don't take care of myself. I don't obviously don't care about my body. If I just did this, if I just did that, if I just, because we've been told that it's a very binary, as I said, very oversimplified, very kind of taking a very complex issue and and trying to distill it down into a few things. If you eat this, if you exercise this amount, if you get enough sleep, then your blood pressure will come, your blood sugar will be normal, your cholesterol will come down, your blood pressure will come down. No, it's not that simple. It really isn't. I wish it were that simple. It's way more complex than that. But in order to fit people into like these little categories of good and bad, compliant and non-compliant, that's what we've turned it into. And it's bullshit. Um, when we focus on these numbers, when we obsess over these numbers, we have a tendency to either overtreat or miss something. That's the problem. It's either one or the other. So we're overtreating a lot of people. For example, there's lots of evidence nowadays that we are overtreating type 2 diabetes and that we are so like trying so desperately to bring the blood sugar down to what is considered normal, and that is actually causing more harm than good. We're overtreating certain things because, of course, every time you start a treatment, there's side effects, there's long-term risks, etc., etc., and it's a real balance. Because, as I said, we're talking about primary prevention here. We're talking about something that hasn't happened yet, that may never happen. We're trying to prevent it from happening. And hey, I don't have a problem with primary prevention. I am going to be the first to tell you skin cancer is a real bitch. Melanoma is something that you really want to avoid, in which case I suggest you use SPF when you go out into the sun, especially if you're unmelanated. I am the first to tell you to get your your cervical pap screening done, even though I am yet to book mine in, and I must remember to do that, but I keep forgetting until I remember again. But yeah, I'm all for like cancer screening of any kind, immunizations. All of this stuff is preventative, right? It's risk prevention. Like I'm getting the MMR to prevent myself from getting measles. I may never come into contact with measles and never, have it, but it's worth it for me, right? And so I don't have a problem with preventative medicine per se. I have a problem with the moralizing of it. And we saw it a little bit with vaccinating, right? I mean, it became a very toxic issue. But I saw it a lot with breastfeeding as well. Like as somebody who breastfed all three children and very pro breastfeeding, don't get me wrong. Like I used to hate the way that people treated parents who were formula feeding as like less than, inadequate, not they don't care about their children, that kind of thing. Because that's not true. So we we either overtreat or we miss things. There's nothing wrong with a bit of healthy, I don't like these words, healthy, but sensible preventative medicine. Nothing wrong with that. Absolutely good stuff. Stopping smoking has been shown to improve health across a number of different illnesses, and it reduces the risk of a number of different conditions, including cancers and heart disease, etc., etc. So I don't have a problem with stop smoking advice. I'm not going to say that that's bad per se, but we have become a little bit obsessed with it. Now, if you're a smoker, you don't care about your health. You don't care whether you live or die. You're a non-compliant patient. You don't care about your risks. You're not looking after yourself. All these moral judgments, not helpful at all. And the same goes for A1C, blood pressure, etc., etc. So in some cases, I think we're overtreating. And in some cases, I think we're missing things because we are oversimplifying. We are missing things because people do not fit nicely in boxes, right? And so, thin, for example, equals healthy. Okay, but there are plenty of thin people who are at risk of developing a heart attack or cancer or whatever, and we're missing it because it doesn't fit nicely into one of those boxes. And we've just created this moral panic. It's becoming like an obsession. Like people are so obsessed about their risk of dying, their risk of having a heart attack, their risk of things. And again, it makes a lot of sense. Like nobody wants to get sick. And also everybody is going to get sick one day. we shouldn't be so terrified. I was so terrified of developing diabetes. Terrified. It was like it sent me into paralysis. For years, I was just not going to see a doctor because I was so afraid they were going to ask me to do an HbA1c and then they were going to find out I was diabetic and I just couldn't handle the idea. Terrified. Not because I couldn't handle the idea of having a condition that, let's face it, is fairly easy to treat. Plenty of drugs out there. It's a relatively easily managed condition. There are some conditions that unfortunately we have very little medication or treatment available. Diabetes is not one of those conditions. So actually, it wasn't the condition itself, it was the judgment, it was the moral judgment, because it had become, like I said, a moral panic. Like we are obsessed with blood sugar in society today. And that was the issue. I want to point out also that there is absolutely a a financial motive behind prescribing or certainly weight loss, but also prescribing all sorts of measures, preventative measures. Think about who's making all the money. Pharmaceutical companies are making all the money, right? Who's profiting from preventative medicine? Pharmaceutical companies, for the most part, especially the ones that are prescribing weight loss drugs, because they're seen as a cure-all for everything. But also the ones that are prescribing blood pressure medications and statins that create, not prescribing, creating, manufacturing, and blood pressure medications, statins, all of those things. They're the ones that are benefiting, right? So it's in their best interest, the pharmaceutical industry, it is in their best interest to create this moral panic because it's going to make it's going to make doctors overtreat, and it's going to make patients much more keen to be overtreated or much more receptive to being treated. And then we've got the weight loss industry. The weight loss industrial complex is profiting from preventative medicine. It's where they make their money nowadays. People are less inclined to buy weight loss for cosmetic reasons, for vanity. Not that I've got a problem with vanity. Much less interested in I want to be thinner and much more interested in I want to lose weight for my health. That has become the driving force of the weight loss industry. That's how they sell weight loss to us. So again, preventative medicine is huge. Look, they are massively profiting. And then there's the healthcare system. Like we have made an awful lot of work for ourselves. We, the medical establishment, have created entire jobs. I remember when the first time I heard of a lipidologist, and I was like, a lipidologist is a made-up word that don't exist. And of course they do. This is somebody who is basically a weight loss doctor. But like, you know, when I was growing up, when I was in medical school, you didn't have the option of specializing in lipidology. There are, you know, when you look at non-alcoholic fatty liver disease, we didn't like we require an awful lot more hepatologists or gastroenterologists that specialize in the liver nowadays because there's this new condition that everyone's getting, and now you have to have a test and you have to have this and you have to see a specialist and da 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 da. We're creating an awful lot of work for ourselves, and the thing about that work is it pays. There's money to be made in that. So who's profiting? Not you, not really. This is a theoretical risk. Is there actually any evidence that all of this preventative medicine works? Well, I mean, that's a tricky question to answer in a podcast. Yes and no. Sure, to a degree, but not that much. It's also this idea that we're going to live forever, right? Like we can't live forever. You're going to get older, and as you get older, your body is going to struggle. Like our bodies do not survive forever. And I don't know, people are always like, oh, don't you want to live? I don't want to live long. I want to live well. I have no desire to live into I mean, I can get into my 90s and I'm healthy and I'm happy. Great, but that's not my driving force. My driving force is living well, but that has stopped being a thing. It's quite weird now to talk about like, or I'd rather die younger, but have a happy life than live into my 90s and develop dementia, but not have a happy life. Do you know what I mean? Anyway, tangent. I think that we have to be very aware of the financial implications to when it comes to preventative medicine, and it goes beyond just like the prescriptions themselves. It's into research fund. We're talking about research funding, medical education, clinical guidelines. the pharmaceutical industry, the weight loss industry, and certain individuals who are profiting from preventative medicine, all of these people are very much involved in research and medical education and clinical guidelines. Like, in fact, they are the ones that do most of this stuff. And so there's like a bit of a, you know, there's a bit of a conflict of interest there. If you're a doctor who's like on a guidelines committee and does all this research, etc., and maybe is involved in medical education yourself and are getting paid by pharmaceutical companies in the weight loss industry, a bit of a conflict of interest, if you ask me. Like if I were one of those people, I'd be more inclined to tell people about preventative medicine too, right? And if the research is there because it's being funded by the weight loss industry, that's even more problematic. Um, yeah, well, there's something to be said there about over medicalizing and fear mongering and medical moralism. I think it's something that I'm going to explore more over time because it's it's churning away in me. But for now, I will say that there are so many more things. Well, no, how am I going to put this? You've all heard of social determinants of health, right? I imagine you have. Um, Access to healthcare, economic stability, racism, ableism, any form of marginalization or oppression, discrimination. Um, it's like food deserts, food apartheids, safe neighborhoods, access to education, prison systems. All of these things impact cardiovascular health, have been demonstrated over and over and over again. And we could go back like in the 1960s, there was something called the Whitehall studies in the UK. Whitehall is kind of where civil servants work. And they sort of studied civil servants. And I remember, like, I don't know much about these studies because they're quite old now and not necessarily, they don't necessarily apply to modern life. But what they found was that income, and like, so they basically looked at like all the civil servants, the ones who had high paid jobs, middle paid jobs, and lower paid jobs. And they found that when it came to cardiovascular health, the more money you made, the better your cardiovascular health. This was, back in the 60s. We've known about this before then. In fact, we've always known about how income impacted our health. Before cardiovascular health, we knew that nutrition and malnutrition impacted our health. We knew that if you were poorer, you were less likely to live longer. That's kind of obvious and common sense. So we've known about this for a really long time. And so the research suggests that the impact of social determinants of health far outweigh things like diet and exercise and stuff like significantly outweigh. And yet medical moralism, like in order for it to sort of to take hold and for people to profit from it, you have to ignore the social determinants of health, right? Because if it's a moral judgment, if it's an individual responsibility, then we can't really talk about social determinants of health. And that is the problem. That is the situation we found ourselves in. We are so focused on preventative medicine, on weight, on cholesterol, on blood pressure, on A1C, that we are forgetting all of the really, really important stuff. Like I said, the social issues, the social barriers, that are actually the parts that are most important. And if we were to address them, would do the most amount of good. But there's no profit to be made from improving neighborhoods and, improving access to healthcare. In fact, it's the opposite way around. You lose money when you do these things. Nobody wants to lose money. So I want to continue on now with everything you've been told about weight loss is a lie. The segment in the podcast where I talk about a study. I've chosen one that I think goes well with this theme. It was published at the beginning of last year. So it's a new study. It's called Evidence for the Association Between Adverse Childhood Family Environment, Child Abuse, and Caregiver Warmth and Cardiovascular Health Across the Lifespan. The Coronary Artery Risk Development in Young Adults Study. CARDIA. CARDIA, Coronary Artery Risk Development in Young Adults Study. That's actually, I don't like the title, as I often say, people really need to work on their titles, but it's a good study, a really interesting study. They followed this group of people for over 20 years in this cohort, the cardio cohort. And they were examining the impact of childhood family environments on cardiovascular health. So you may well have heard of childhood um, adverse adverse events, or ACE scores, adverse childhood events. Uh, and they were looking at child abuse. They were looking also at caregiver warmth, which was really interesting. Um, and they basically they used various questionnaires. They tracked their cardiovascular health over 20 years. They also looked at things like smoking and cholesterol and blood pressure and all this other stuff. So it was a pretty decent study. It's been around for a long time. So I just want to tell you the highlights of the study, because I think really it's fascinating and there are plenty of things to be said, but here are the highlights. You will not be surprised to learn that higher childhood adversity was linked to poorer cardiovascular health in adulthood. So it's not going to come as a shocker for any of you, is it? Higher childhood adversity was linked to poorer cardiovascular health. And each unit increase in adversity reduced the odds of ideal cardiovascular health by 4%. And so there was a linear relationship. The more adversity you experience in childhood, the worse your cardiovascular health is. And when we see that kind of linear relationship, we tend that not always, but often gives us a kind of sort of supports the idea that one causes the other. We can't say for sure that adverse childhood events cause poorer cardiovascular health. And also we have to figure out why they cause poorer cardiovascular health. But when we see this linear relationship, that's quite a strong association, for want of a better word. Childhood abuse was associated with a 13% lower likelihood of achieving ideal cardiovascular health. And caregiver warmth increased the likelihood of achieving cardiovascular health by 12%. And so the association between childhood adversity and poor cardiovascular health persisted in those with higher adult income, but was not significant in lower income groups. So what that shows is that actually there's a difference. If you were born into a higher income family, then then your experience in childhood, for example, child neglect, child abuse, and also how warm your caregiver was, whether you experienced a safe and happy childhood, for want of a better word, that has quite an impact on your cardiovascular health. However, if you're in a low income group, it has much less of an impact, because having a low income is enough to cause damage to your cardiovascular health, with or without the childhood adversity. Isn't that interesting? So it's both income and childhood adversity. I grew up in a fairly middle class home. I say fairly, it was middle class, not fairly, it was middle. Child of immigrant parents, but middle class. And I grew up with quite a bit of childhood adversity. I have a relatively high ACE score. And so my risk of poorer cardiovascular health is higher because of that, because I didn't have that warm caregiver that some people have. That's a real privilege to grow up in a family, not only with a higher income, but with a warm caregiver, to not experience neglect or abuse, physical abuse, mental abuse, etc., etc. So I want you to remember this next time you're stressing about your blood pressure and your cardiovascular health. I want you to remember that actually a lot of what is going on has already happened. You had no control over who you were born to, or when you were born, or where you were born. Like it just happened, right? And all of this stuff happened in childhood. And unless you're a child listening to this podcast, which I assume you're not, it's done. And the reason I'm telling you this is not so you can feel really shit about your life, because like I said, it's a theoretical risk, folks. It's just a potential thing out there. And also these numbers are not that high, 12%, 13%. It's not like 100%, is it? So there's no guarantees in life. But you also have to remember that this is far more powerful than diet. You're not going to find 12% or 13% when it comes to diet or exercise. It just doesn't exist. Certainly not with weight loss. So remember that. Remember that your childhood is one of the many reasons, many, not one, it's just one of the many reasons why your risk is what your risk is. And therefore, it is not a moral judgment. It's just one of those things. It's just, it just is, right? And it's not something you need to feel bad or ashamed about. Um, Last but not least, I received a couple of questions that were very similar, so I have meshed them together for the Ask Me Anything portion of this podcast. Basically, two people who are in recovery from binge eating disorder, and neither of them are restricting, and basically, like they're in, like from what I could tell, they're in a good place. So they are sort of intuitively eating, they're allowing themselves to eat what they want, etc. So for the most part. Um, However, their eating disorder professionals have instilled in them that binge eating disorder is really bad for your health. And there is this real worry now that, like, but how is it bad for my health? Like, which part of it is bad for my health? Should I be worried? Especially because people who are have a history of binge eating disorder and in recovery may well binge from time to time. Um, and so there was a kind of fear, I guess, of what does that mean? And so I did a little bit of research into this because, we know that eating disorders are bad for you. Like we know that they're bad for you, and we know that binge eating disorder is bad. But when you actually look into like any of the studies, there is an automatic assumption if you have binge eating disorder, you eat a lot of food. A lot of food equals fat. Fat equals unhealthy, and they don't like. There is no like that's just an assumption that is made. there's there's no effort been made to sort of challenge that or to ask, well, actually, what are the risks? And I couldn't find any evidence. Just because you eat certain food, does not necessarily mean that that's bad for your health, right? I think, from what I can understand, it's probably more the emotional and mental health implications um, rather than the physical health implications when it comes to binge eating disorder. But there really isn't enough evidence because, once again, we are so obsessed with weight and we are so sure that weight causes disease that we never think to question it. From what I can tell, folks, the most important thing is that mentally and emotionally you're well, energetically you're well, socially you're well. The second most important thing is that you're not restricting, because restriction leads to weight cycling. Weight cycling is harmful. Weight loss isn't an option. Obviously, with a history of an eating disorder, weight loss isn't an option. And so we find ourselves in a situation where, if you are binging from time to time, and that's where you're at, what are we going to do about it? How are we going to get you to stop? Now, there may be room for like understanding, like what's causing you to binge, why is it happening? Are you speaking to a health professional about that? Maybe you're going to therapy or you have a coach or it's a community that you're speaking to. Like, sure, like I'm sure there's things that can be done here. But ultimately, it is what it is. What are you going to do about it is the question I'm going to ask. What will you stop if I told you to stop binge eating today, stop binging today, would you stop? Um, I think the fact that you've stopped restricting is fantastic. I think the fact that you're in a much better place now than you were before is fantastic. I think the fact that you've got support is fantastic. I think the fact that you're unlearning beauty standards and body ideals and all of that stuff is fantastic. And I think you're doing the very best that you can. And sometimes the very best that you can is enough. In fact, not sometimes, always the very best that you can is enough. We don't need to be perfect. And I think it all comes back to the fact that there is um such a moral obligation now, such a moral judgment when it comes to our health, that we really panic, and it causes us to really question so many things. Like, is this okay? Is this not okay? What do I need to do? How do I do it? When do I do it? What do I? And really, I feel like just saying to people, whoa, it's okay. Slow down, relax, enjoy life a bit more, worry less about your blood pressure, I'm not saying totally ignore it either, but actually we know that the more you stress about it and the more stigma you experience, the less likely you are to actually address these health issues. Like I said, I didn't go and see a doctor for years because of the fear of getting diabetes. And then I got diabetes, and then I realized, oh, it is what it is. And there are days when I hate myself for it, but more and more now, I'm just like, it's a health condition, just a condition. There's nothing I can do about it. There are no good and bad patients. There are no compliant and non-compliant patients. I don't have a responsibility to look after my body and to reduce my HbA1c and, to prevent my risk of this and that and the other. I don't. And in fact, that's what we're going to be talking about a little bit more next week. In next week's podcast, episode 15, we'll be talking about how their health status does not define your worth. That's what we'll be talking about. Hope you enjoyed this episode. Don't forget, Weight Inclusive Wednesdays is coming up on I should say that will be next week. Yes, so it will be Weight Inclusive Wednesday is next Wednesday the 16th. For those of you who are members of No Way or the Masterclass membership, you automatically get access to Weight Inclusive Wednesday. For those who want to join, it is just a really safe space to have conversations, to form community, to discuss problems, highs, lows, anxieties, worries. It's just a safe space that I'm creating. It's a small fee to join. And if you're low income or if you have multiple marginalized identities, you can get it. You get 50% off. If you want to find out more, click the button in the show notes. If you're not signed up for my newsletter, then you could sign up for my newsletter, and then you would get access to all of this information. I have, as I said last week, dropped it down to one newsletter a week. There's one newsletter a week from me and one newsletter a week from No Way. If you're signed up to No Way, you don't have to be signed up to both. Yes, trying to think. This month's masterclass will be on high cholesterol for those who are in the masterclass membership or who just want to watch the high cholesterol one. That comes out next Tuesday, the 15th. And thank you very much for listening, and I will catch you next time.